Doing like, I think we're live. Awesome.
Hello, Stephen.
Hello, Dr. McGrath. How are you doing?
I'm doing well, thank you. How are you?
Good, good. Are you staying indoors, social distancing yourself?
Yes, I social distance myself from myself sometimes even. I'm trying to figure out how to do that, so we'll see if it works.
Well, it's great. It's great. Well, thank you for taking the time. I know both of us are really excited to talk about OCD and the impact of evidence-based OCD treatment. And and I know just for everybody who's listening, Dr. Patrick McGrath is a world-renowned OCD psychologist. And do you want to introduce yourself?
Sure. So been treating OCD for 20 years now since my postdoctoral fellowship after getting my doctorate degree, and have opened up intensive outpatient programs, partial hospital program, residential treatment center for OCD, as well as training people all over the world. Got privileges to go to Turkey and Italy and to Australia to do trainings with people. So my work with OCD has been amazing. I've got books out on OCD and stress management. I'm on the scientific advisory board for the International OCD Foundation and also president of OCD Midwest. So a lot of my life has been devoted to working with people who have OCD and trying to make that darn disorder just go away if we possibly can.
Definitely, definitely. And Dr. McGrath, would you like to talk a little bit more about what you do at NOCD?
Sure. So I'm the head of clinical services now at NOCD, where primarily I'm working on helping to train our therapists to become evidence-based providers of exposure and response prevention therapy for obsessive compulsive disorder. I'm involved in the hiring, the training, the writing the protocols. We'll be launching our child and adolescent protocol soon for NOCD, so that's very exciting. And all around working on just the technical aspects of our electronic health record and supervising our team. So it's been a wonderful 6 weeks so far. Whirlwind, but what a great time.
Excellent. And what got you into OCD treatment?
So kind of a funny story, but I use this story actually a lot when I talk to patients, because a lot of my patients who are perfectionists will talk about their big failures. And I'll say, well, if you're a big failure, then you won't want me as a therapist because I'm a massive failure. And I talk about all the times that I applied to graduate school and that I applied to internship and fellowship. And when I was applying to my postdoctoral fellowship, I applied to 40 different places and I got in one. And that was the St. Louis Behavioral Medicine Institute and their anxiety program. That's where I went. And that one thing that I got in, even though I got 39 rejections, turned into an amazing career for me. And who knew that this is what I would be doing for the rest of my life, but I can't see doing anything else.
Yeah. Awesome story. That's an awesome story. And, we're very excited to have you on today. And also it's just incredible having the chance to work with you so closely now at NOCD. So we've been doing a lot of great work, which I'm sure we'll get to later on, but I'd love to introduce myself as well. My name's Stephen Smith. I'm the founder and CEO of NOCD. I'm also here with Made of Millions today to talk a little bit about obsessive compulsive disorder. And I'll be here for the next several weeks talking about elements of the condition as well as how it's treated using exposure and response prevention, acceptance commitment therapy, and other evidence-based treatments. I actually have OCD, and that's what led me to creating OCD, as well as going and becoming a part of this podcast, right? So I have the condition. I got a severe onset of it when I was a sophomore in college, where I was a college football player. Everything was going great. After I returned home from summer break, I started having a severe onset of intrusive thoughts. So people oftentimes think of OCD as a personality quirk, when in reality is people have these intrusive thoughts, images, and urges that get stuck in their head, and they typically violate their most fundamental elements of their character. So you have these thoughts that are incredibly distressing, and to get them to go away, people with OCD do these actions called compulsions. And so that can be mentally reassuring yourself. It could be Google searching to try to find the logic behind why you're having the thoughts, because if you can find the logic, you can make it go away. It could be checking doors. It could be reviewing past events, a variety of different things. So anyways, I started having a severe onset of OCD, intrusive thoughts. Ended up getting misdiagnosed 5 times. I had to leave school. I stopped playing football. I became housebound. Then I developed severe depression. And when I was kind of at rock bottom, I started searching my symptoms online, and I saw that other people were going through the same thing. and they defined their symptoms as OCD. And I was like, OCD? I thought that was just, keeping your room in order. I had no idea it was such a disabling condition that affects about 1 in 40 people and causes people to be 10 times more likely to die by suicide when left untreated. And so my next logical step was, well, where do I go and get treatment? How do I get better? I want these thoughts to stop. I want the anxiety to stop. I want to get my life back. And so I started searching OCD treatment, and I saw in my area there was one therapist that specialized in OCD, and they used a treatment called exposure and response prevention to help people with OCD. And I learned after the fact that it's the gold standard. And second, that person had a 7-month wait list and charged about $300 out of pocket per session. So my only chance to getting better was to see this person, yet there were so many barriers in doing so, given they had a wait list and they were extremely expensive. And so the next step that, I had was I tried to figure, well, how do I go pay for this? And so I was fortunate enough, a family friend came in, covered the cost of my care. I ended up going to see that therapist, ended up getting better slowly but surely, because, again, it's a chronic condition, but you only are able to see your therapist once a week. Got back on my feet, went back to school. I went to Pomona College in Southern California. I finished up my degree, finished up my football career, and was like, if you get treatment for OCD, you can get better, right? And that's really, really special, considering that so many people out there are suffering today, and I'm not sure if they know that. And so the next step was, well, if clinically there's really effective treatment for OCD, but operationally it's really inaccessible, how can we fix that? And kind of with that problem, started brainstorming and eventually created an OCD. And so what we do is we provide online therapy for OCD, and people can basically download our platform. They can do live video therapy sessions with our therapists, licensed psychologists, licensed counselors, and licensed social workers. And Dr. McGrath oversees all of the clinical protocols, and as well as oversees the training and management of our therapists. And then in between sessions, when the therapist isn't around, you can go and get support from our peer communities, as well as you can utilize OCD specific self-help tools to better adhere to treatment. And so, today also we've been doing a lot of work in just informing people about OCD and what it is, how it's treated. And so the goal of this series is to do that, right? Is to educate the world about this condition, knowing that if you can understand it, then you can help drive treatment for people, right? And so that's the goal today. And to kick us off, Dr. McGrath, do you want to talk a little bit about what is OCD?
Absolutely. So OCD is two things. You have obsessions, which are intrusive thoughts or images or urges. And I want to just take a moment on that just to say, most people talk about obsessive thoughts, but really urges and images are very intrusive in people's mind too. They may see a picture of something that they think is blasphemous or bad or wrong. They may have an urge of, what if I were to push somebody into oncoming traffic or something like that? So there's a group of things. Now, typically when people talk about it, they'll talk about OCD thoughts, but I just want us to remember that it includes urges and images as well too. And as you have on the slide, I think many people in society think OCD is orderliness or cleanliness, or it's washing your hands because you're afraid you're going to get contaminated. But what we see at NOCD, and what I have seen in my career, is OCD is intrusive thoughts about, what if I ran someone over with my car? What if I were going to push somebody into a train? What if I was, even though I identify myself, say, as straight, what if I suddenly became gay? Which is not a negative about being gay. It's just about, what if I'm suddenly not what I think I am? It could be that things have to be in an order or symmetry, but that could even lead to things leading to a fight. I've seen people who got bumped into on one side of their body and chase that person down to bump in them on the other side of the body. And then that person's like, why the hell did you just bump into me on purpose? And so that could cause problems too. So OCD is so far beyond what our societal definition of, and it's beyond what is a joke too. I mean, there's so many movies or TV shows that have said OCD is this funny thing, and no one who suffers from OCD considers OCD to be a funny thing whatsoever. And we've even seen people with the virus out right now saying, oh, I wish I was a little more OCD. And the standard reply is, no, you don't. That virus is even more stressful than to people with OCD. And we wouldn't want something like that to happen to anybody. So we have lots of different themes that OCD can come in terms of contamination, harm. What if I become a pedophile? What if I become straight if I'm gay, gay if I'm straight? but you'll notice that all these things start off with a what if. And it's what if, and then enter your worst case scenario there. That could be what you obsess about. And then the other side is compulsions, where you do something to neutralize those obsessions. And that could be related to it. Like you might want to hold onto the railing when there's a train going by to make sure that you don't run over and push somebody. But it could be totally unrelated too. So now a train's coming by and there's a person there, and I start saying a prayer saying, please God, don't let me go over there and hurt anybody. And then when the train goes by and you didn't do it, you think, oh, that prayer worked. God stopped me from harming everyone. Now I need to keep doing that in order to make sure that I don't harm anyone. So it's two things. It's the appearance of obsessions, and then these neutralizing things called compulsions or rituals that we do to try to make the discomfort that we feel from the obsession go away. Of course, the problem is that just grows and grows over time, and people become consumed with all these compulsions they have to do because they think that's the only thing that stopped the obsession.
No, I think it's a great explanation. And I think too, to add, like, what does it feel like? It feels like you're literally imprisoned in your own brain, right? Yeah. You feel like you wake up in the morning and you basically think, oh, please, I wish I don't have this thought. I really don't want to have this thought. And then all of a sudden you have the thought, and it almost like is a constant spiral throughout that day until you go to sleep. And you're consistently trying to figure out that thought, why you're having it, trying to disprove that thought. You're trying to, potentially just ignore the thought sometimes because you're like, I just wish I could think about something different. And then you go to sleep and you feel exhausted, and typically, you don't really feel as if that day was productive. And so people suffer with this internally, and you can't even see it, right. And which is very, very disabling. And that's why I think sometimes this condition is so misunderstood, because unlike other mental health conditions, which oftentimes show a lot of outward distress, for OCD, you may see somebody doing a compulsion, but you may not really understand why they're doing it. And so, that's what's interesting about this condition. And so to help people understand what it feels like, we're going to do a little exercise, because I think, Dr. McGrath, you really do a great job at helping people who don't understand OCD quickly understand it through these different exercises. And so I would love if you could just take it away and, help explain to the audience really, what does OCD feel like?
Sure. So what I want all of you to do, I'll give you a moment. You can either pull up another screen or your notepad or something like that, get out a pen and a piece of paper, and I'm going to give you some instructions in a minute. So I'll come back to that in a minute. But Stephen, I want to add one thing to what you said too, which I think is very important. And that is, you don't always see that people suffer physically, because not all compulsions are done physically. There's so many mental compulsions, and people are just tortured internally. So this is a problem sometimes, because people will look at you and think, well, you're not suffering, you look fine. They can't see the torture that's going on inside of your head when you're doing those mental compulsions.
Right. There's a reason why OCD is ranked by the World Health Organization as a top 10 reason for disability, right? It's because people suffer so much with it, and you wouldn't wish it on your worst enemy. It's just such a crippling condition. And so I think you'll quickly learn with this exercise why.
Yeah. All right. So here's what I want everyone to do. I want you to get your pen out or be at your keyboard, and I want you to type the following. I want you to type or write, I hope, and then write the name of someone that you love, and then write dies tonight. Now, some of you just threw your pens down and thought, no way am I doing that. I'm not going to write it. I don't want to do that. Some of you probably chuckled and thought, that would be weird. I don't want to do it. Maybe some of you wrote it and then scratched it out right away, or maybe you wrote it and then crumpled it up, or you typed it and then you deleted it. But what I want all of you to recognize is, how uncomfortable did it feel even just to have the thought about writing that down? Now, I always practice what I preach, so I will show you that I wrote down, I hope Susan dies tonight. She's my wife. I've written that down for all of you to see. And I'm not afraid that me writing that would cause anything to happen to her, because I know that I don't have any superpowers. I'm not a mutant. My thoughts don't make things happen. In the OCD world, we call this thought action fusion, though. And that's the idea that a thought is as bad as an action. So if you felt amazingly uncomfortable from that one experience, Imagine what it would be like if a thought like that popped into your head 400 or 500 times a day. And every time it did, you would have to then say a prayer, scratch it out, tell yourself, no, I'm actually a really good person. I really don't want that person to die. Or you might even pick up the phone and call on them and check on them to make sure they're still alive, just to be sure that what you thought didn't cause them to die. And think about the amount of time that that might take out through the day. So if the thoughts take an hour a day, and then the compulsions take another couple of hours a day, you could spend 4 to 6 hours of your waking time just doing this and dealing with that intrusive thought and trying to neutralize it, just to make sure that you don't cause something harmful to somebody. Now, you can see how intrusive in someone's life that could be. What do you think on that, Stephen?
Yeah, I think it's a great example, right? And the thing about OCD is it feels real. So when you're going through your day-to-day life, you have certain thoughts. You can kind of differentiate the ones that are like, oh, that feels ridiculous, or that's strange. And you can also understand the ones that feel somewhat real, and you tend to, think more about those ones. For OCD, it's kind of like this weird hybrid where it's irrational, but it feels so real, and that's why it's so disturbing. Because you understand logically, like, how could that happen? I just had this thought that doesn't really mean anything, but your body is saying this feels real, and so that's why it gives this incredibly discomforting feeling when you have the thoughts.
Yeah, that thought triggers the fight, flight, or freeze response. So you have an amazingly powerful emotional reaction to it. And what my patients often say to me is, how could I have such a powerful emotional reaction to something if it wasn't real? Therefore, it must be real, because look at the reaction I had to it. There's no way I could have a reaction like that to something that wasn't real.
Right. And so, Dr. McGrath, would you want to talk a little bit more about examples that you've seen, in terms of what types of OCD thoughts people face?
So harm is a big one. And in fact, harm is one of the most common types of OCD that I treat. And years and years ago, one of my very first patients actually had an intrusive thought about, what if he were to dig up his mother from her grave and cut off parts of her body with a toenail clipper? And you can imagine just how awful that would feel to have that thought hundreds and hundreds of times a day. And he would cry, and he would call his brother, and he would apologize constantly. And he believed his mother was in heaven, so he was praying to heaven, just, Mom, please forgive me for all of these thoughts that I'm having. And he thought, what a horrible person I am for having these thoughts, right? And Stephen, you would know this from, I think, probably your own type of OCD, that we feel so bad for having the thoughts we have. And if we could just have any other kind of thought, that would be fine. But why does it have to be this thought, right?
Right.
If anything else would happen, I could deal with it, but I can't deal with this one. And of course, OCD knows that, right? OCD knows which thought would be the hardest for you to deal with. And that's why it presents that one to you. Mm-hmm. And it tells you, of course, not to think of it. And so this guy was tortured then by trying not to think the thought. And as you know, once you attempt to not think of something, what happens? You think of it, right? So he was stuck all day long thinking this thing that was awful. Now, it leads to, what do we do for treatment for someone like that? Well, guess what? He'd been to a bunch of therapists who all told him, oh, stop thinking of it. Put a rubber band on your wrist and snap the rubber band every time the thought comes, and that will punish the thought out of you. Picture a stop sign in your head, and that way, once you have the stop sign in your head, you'll stop thinking it. What did we do for treatment? We did the opposite. We got pictures of her mother, and we got toenail clippers, and we cut off parts of her body from the pictures from with the toenail clippers.
Yeah. And we're going to talk a little bit more about that here in a few minutes. Mm-hmm. But it's kind of like the journey that many of us face, right? You basically go and you'll see a clinician, and they'll tell you the wrong advice that maybe misdiagnose you, and then you get worse, right? And I can personally relate to that, Dr. McGrath, and that's kind of what happened with me. So like I said before, I was a former college football player. I played quarterback. Things were great in school. Had great grades, great social life. Everything was perfect. Once I was getting severe with OCD, though, I'd go and see a therapist, and they would tell me every time I have a thought, take a rubber band and snap it on your wrist, right? And I get worse. I would then go to another therapist, and they'd say, I want you to go and move away from your family, because I think your family could be causing this issue. And I get worse. And then I even go to some therapists, and they'd say, okay, we're going to do some electromagnetic stimulation, and we're going to attach some wires to your head, and you're going to see if that works even to stop these thoughts. And so in this picture, you could see, I was in this situation midway through OCD, getting this electric stimulation to my brain, and it really didn't do much. It didn't do anything. In fact, it got worse. And so you could almost see before, here's how happy I was. You could see it in my face. You could just look at the suffering in my face during, right? It shows you what happens when you don't get evidence-based treatment. You get worse often. And then when you do get treatment that's effective, you get better, right? You could regain your life. And that's what happened with me. I was able to go back to school, finish up football, finish up my degree, and I almost returned back to normal. And so that hope is available for people if you go get effective treatment. And that's why we're doing what we're doing today. We're basically here to educate how to get effective treatment for OCD, considering that's what often gets people better. It's just finding that clinician who's specially trained and who can offer exposure response prevention, acceptance commitment therapy, can help you do mindfulness, especially when you're asked to respond. And so we're going to talk a little bit more about that right now. And the good news is Dr. McGrath is an expert here in exposure response prevention. And like you said, he's been treating it for about 40 or 25 years. And, it's just amazing to see how many people he's gotten better. So I hope in this point of our series, you could really listen in and understand what Dr. McGrath's about to say.
Sure. So how does this work? Well, there's some kind of a trigger that leads to the obsession. Now, that trigger could be an environmental thing, and it could just be your own brain kind of telling you, hey, don't think about this thing, right? Because that'll happen in OCD, where OCD likes to kind of scan and monitor and be like, oh, hey, you haven't thought about this for a while. That's good, which of course makes you think about it. So what happens? Well, you get all sorts of distressed, and then what do we want to do when we're distressed? Well, when we have OCD, we want to do a compulsion, because we've learned that that's the fastest way to make distress go away. Even if the compulsion might take hours and hours to do, it's still better than sitting with it and taking the chance of something bad happening. So we do it. And what occurs? Well, we get some temporary relief. And what does that teach us? If I want relief, continue to do compulsions, because it's doing the compulsions that brings about the relief. And that's what's going to keep me safe. So over time, people just do more and more and more of these over time, and their life gets significantly more difficult over time as they do that. What do we want to do for treatment? Well, what we want to do is recognize that an obsession really is just a thought or an image or an urge. It doesn't actually make something happen. So back to our exercise earlier, I still don't believe that writing down, I hope Susan dies tonight, is going to cause anything to happen, because I don't think that thoughts cause things to happen. If they did, I don't think any of us would be alive. Only one person would have to think, I hope nobody else is alive tomorrow. We'd all be gone. So thoughts don't make things happen. So when somebody has that intrusive thought or image or urge, and they get the distress, instead of doing a compulsion, what do we want them to do? We want them to do response prevention. We want them to work on eliminating doing the compulsion. We want to eliminate all the reassurance that they get from people in their lives and from the activities that they do themselves to make them feel good instantaneously. And we want them to sit with the discomfort and learn that they can handle the discomfort. We want them doing it without distraction. We want them fully engaging in the experience. We want them to feel that discomfort all the way through and learn, I can handle it. We don't want them using drugs or alcohol as a way to deal with it, but that's what a lot of people jump to, right, is a way to deal with it and neutralize some of the thoughts that are going on by just kind of zoning their brain out as much as they possibly can. And we don't want people avoiding things. So you were instructed, Stephen, as you said, to avoid your family, to move away from them. And that didn't help, right? That probably made things worse, actually. So what do? We eliminate safety behaviors of avoidance, reassurance, distraction, substance use, and compulsions. And we have people learn, I can handle the things that pop in my head. I don't need to be afraid of them. I don't need to worry about them. They're not going to cause something bad to happen. And I can handle the distress. So that's my message to my patients all the time. I don't tell people you'll be fine or you'll be okay. I say to people, you can handle it. You may not like it. It may not be comfortable, but you can handle it.
Can I ask a question, Dr. McGrath?
Please.
When I was going through treatment, everyone would always say ERP, ERP, ERP. And for the exposure part, I was like, oh, that makes sense, right? But the response prevention was always something that to me was it wasn't as intuitive, because it's like, well, how do you do response prevention? How do you tactically do that in your life? I mean, exposure, yeah, especially if you have a fear, you go and expose yourself to your fear.
Sure.
You may naturally and randomly at times get exposed to your fear without you even planning it, right? You could be just walking down the grocery store aisle and all of a sudden, boom, you're triggered and you're under extreme distress. But how do you do the response prevention? If you have people who were looking to do response prevention today, what would you instruct them to do?
I build it up gradually. So I've been using this example lately, Stephen. When a kid starts in baseball, we put a tee out and we put a ball on the tee and they start swinging. And then after they get used to that, then a coach is softly pitching to them. And after that, it's a fellow teammate that's pitching to them. And then it's the opposite team. And then they go to Pee Wee and the ball comes now at 30 miles an hour. And the next year it's 40. And the next year it's 50. They get into high school, it gets up to 60. They get into college, it gets up to 80. By the time they're in the minors, it's at 90. And by the time they get to the big leagues, it's 110. You would not take a 4-year-old and throw a 110-mile-an-hour fastball at them and tell them, just stand there and try to hit it, right? You slowly and gradually over that person's life have built them up to being able to do the really difficult thing. And
Right.
that's what we want to do with response prevention. We start people on low-level things that they're afraid of. Like, think of it as a ladder and take that first step. What's the first step into doing something? Ultimately building up to the thing you're ultimately afraid of and learning all along the way. Well, I handled that. And then I handled that, and then I handled that, and now it's one more step to handle that, and there I am.
I guess my question too is off of how do you do the response prevention? So that explains the exposure, right? How do you actually do the response prevention? So you're getting that hypothetically 30-mile-an-hour fastball. How do you respond? Like, I know, people are always saying accept uncertainty, accept uncertainty, accept uncertainty. How do you do that? So I guess if you were talking to someone with OCD today, what would you recommend they do when they're doing response prevention?
I would ask them, well, like you said, accept uncertainty, but what I use is examples in their own life. I'll say, when you go out and drive in your car, there's always some uncertainty if something's going to happen. You never really 100% know that you're going to get where you're trying to go, right? There could always be something. So the thing is, all of us in all of our lives accept uncertainty on a daily basis. When it comes to OCD, though, we have a different rule, which is, it's okay to have uncertainty in all these other areas of my life, but it's unacceptable to have uncertainty in this area of my life. In this area, I have to have 100% certainty. So I want to really work on convincing people to be able to do what they do for the rest of their life, which is to work on accepting that uncertainty about OCD just the way that they accept it in every other way of their life as well, too. And that will only come by practicing it and doing the exposures and allowing themselves to sit with that discomfort. And here's the response prevention part. How do I sit with something that's uncomfortable and not do something to make it go away? And the answer, of course, is you allow yourself to be uncomfortable and you allow yourself to let that discomfort pass over time. And that's what will happen. It will pass over time, or your belief about if you can handle it will change over time because you'll learn that you don't need to be so afraid of it. Right. So my goals in response prevention are always allowing that time to let that discomfort pass, or allowing my beliefs to change and learn I can handle this.
Definitely. And to add to that too, a tactical example that I oftentimes embodied when I was, going through treatment, I had a lot of the intrusive thoughts, the mental compulsions.
Sure.
I would, instead of saying what if, I would, basically put in the word maybe instead of that what if. So maybe that could happen. I'll accept the uncertainty, move on. So Absolutely. What if that happens? Right. So just almost replacing that phrase what if with so what or maybe. That was an example. That was something that I did that worked really well, that helped me accept uncertainty. And so I think it's interesting though, because we talk in our environment today, people are always talking about the exposure, but the response prevention is really what makes you better over time, because you're learning how to essentially respond to that fear that gives you so much distress. And so there's a lot of mindfulness-based work that people have been doing to help accept uncertainty. There's a lot of acceptance commitment therapy that's been done too. So there's a lot of a lot of ways you can respond to your fear. And I know a little bit. So Dr. McGrath, do you have anything to add to that?
I would just say one other thing that I've liked lately in talks I've done, which is I've asked people to consider going with your second thought. So if your first thought is like the worst case scenario thought that jumps into your head right away, and that's what happens when you have an anxiety-based kind of problem, often the second thought that pops in people's heads is a little more mellow, a little more calm, and sometimes even the advice they might give to someone else. So a great way to consider response prevention might be, would you tell someone else to do what you're doing? Or if you wouldn't, what would you instruct them to do? And then what if you went and did that then? And I think that that's my easiest way to get people to think about response prevention. It is the great advice you would give a loved one is probably the best thing for you to do, not the immediate fear-based response that you do on a daily basis.
Definitely, definitely. And I think all in all, exposure response prevention is you basically stop doing the compulsions, right? That compulsion is what ends up driving OCD worse.
Yep.
You're in the treatment, you're learning how to not do those compulsions. And
Right.
if you don't do the compulsion, your anxiety is going to naturally decrease over time, and you're going to learn to manage it. And once you learn how to manage without the anxiety, then the thought stops really, happening as frequently. And then you just live like you normally do, right? And that's kind of the nice part about OCD is that it's there's nothing nice about it, but it's really treatable. If you get the right treatment, you can get better, and that's something that is important. And that's why Dr. McGrath and I do what we do. We run NOCD largely because we want to help people who typically can't access effective care get effective care. And so that's our mission. And so to kind of conclude things, I know we're running out of time. Are there any questions from the audience? Any questions that you have about OCD treatment, anything that you'd like to ask? If so, please feel free to post them in the comments, and Dr. McGrath and I will respond.
Steven, can I ask you a question while we're waiting for some comments?
Sure.
Looking at the depths of where you were in your OCD, did you ever consider that you'd be where you are at now, or did you think you would that was your life for a while?
I thought that was my life. I would remember going back and saying, I know the exact date in which I had my first intrusive thought, and I'd almost have like monthly anniversaries, and then they became annual anniversaries, saying, oh my gosh, I can't imagine it's been already 7 months, right? Then it became 13 months, and so on and so forth. And I just remember how life was so challenging. And then after getting better, things, just got kind of back to normal. And they got, in fact, better than they were. And if you were to tell me that, we'd be in this position today, I would probably laugh at you. I'd say, there's no way my life's going to be like this forever. But the good news is if you have OCD, you can manage it, and then you start, dealing with problems that are typical life problems, right? And that's a good thing.
And where do you think you pulled that motivation from? Because there may be someone out there listening right now who says, okay, that's fine, Steven, you were able to do it, but I can't. And I'm going to bet you thought that at some point too. So what would you say to someone who's at that kind of depth of where they just think there isn't help for me? What would you say to them?
I would say there's incredible help available, right? And the good news now is there's, because of telehealth, no matter where you live in your state, often you can access effective OCD treatment, right? You can do live video therapy sessions with licensed therapists who all they do is treat OCD. You can do that. It's affordable too now, right? There's so many things that are happening out there that are specifically for getting people with OCD better. And so I would relay that message to people who are suffering today, because if you can just get to an effective therapist who treats OCD, who is experienced, the chances of you getting better are very, very likely, right?
Significant, yeah.
Yeah, and 80% of people who do the exposure and response prevention with an OCD therapist get better, right? Within oftentimes 20 sessions.
Right.
And that's that they can regain it. So that's the really exciting part. So I just would urge everybody go and see an OCD specialist therapist who can provide evidence-based treatment.
We got a question from Alex here. It says, is it possible to completely recover and completely stop the rumination process for multiple themes?
Yeah, that's a great question, Alex. I think recovery is a broad term, right? I think 100% of people have intrusive thoughts. The difference between someone with OCD and somebody who doesn't have OCD is people with OCD magnify those thoughts and they try to decipher the meaning behind them, right? And instead of just letting them naturally transition throughout the day. And so the goal of OCD treatment isn't to stop the thoughts from happening. It's to change your response to them. And if you can change your response to them, you will get better and live just like how everyone without OCD lives. And that is where I'm at today, right? So it's definitely possible to get much, much better.
Yeah, and I'll say from a therapist point of view, I've treated OCD now for so long that I've kind of absorbed a lot of intrusive thoughts from people. So if Stephen and I are ever standing at the top of a staircase, I will think about pushing him down the stairs, only because I've treated people who have had that problem before, and now I just remember those types of things. And I learned to live with the fact that there are thoughts that pop in my head too, and that we don't have to do things to neutralize them. So
Definitely.
as Stephen said, everybody has intrusive thoughts. They're there for everyone.
Definitely. Dr. McGrath, here's a question for you from David. Hey guys, I also struggle with motor tics as well as OCD. Would ERP still be the best method of treatment? My tics are definitely compulsions.
Absolutely. And tics can be part of an exposure therapy regimen. Doug Woods is a great treater of this. And if you go on YouTube and you look him up, you can look up some of the things he does with something called habit reversal, which is a form of doing exposure therapy specifically for tics. And as you said here, sometimes people with OCD, the tic becomes part of the compulsion as well too. So we would address some exposure and response prevention around not doing the tic and sitting with the discomfort that you have of not doing the tic, allowing that to pass without the tic happening, and learning I don't need the tic to neutralize things. I can let it pass on its own.
Sure, definitely. Great. And then, so we have another question. How do I do exposures when my HOCD, ROCD comes as feelings and lack of emotion towards partner?
So the fear is probably around the idea of, what if I don't have feelings or emotions about my partner? And does that say something about me, about how I am as a person or how I am in this relationship? Almost as if OCD has said to you, there is one kind of feeling you're supposed to have, and if you don't have it, then that means something's bad or wrong in your relationship. And I'm married, and I can tell you there's a wide range of feelings that I have throughout our time together as we're together. It doesn't mean the second that it's not what I think it's ideally supposed to be, that, oh, we're done, that's it, it's over. But with OCD, it starts leading you down. Oh, does that mean that you don't want to be in this relationship anymore? Or does that mean you don't like her anymore? You know, those types of things.
Yeah. Levante, this is actually one of the issues I personally struggled with. And so I'm going to kind of talk a little bit about my story here in hopes that it could be somewhat helpful. You know, for me at least, I'd have a lot of times the similar intrusive thoughts, and I'd almost automatically do mental compulsions where I would essentially have an intrusive thought and I would almost try to disprove it or push it out of my head right away because it caused so much distress. And so what helped me was first identifying the thoughts and identifying the compulsions that I do. So I would say, oh, that was just an intrusive thought. And maybe I just did an automatic compulsion. Here's what it was. Here's my response. Here's what I should have done instead. And I started becoming really cognizant about the thoughts as well as their reactions to them. And then what I would do is I would just start applying, I would just start applying the acceptance. I'd say, well, what if that happened? That could happen. Maybe. Who knows? I don't know if it will happen. And I would just accept it. Even though I'd feel a lot of distress, I would almost verbally in my head accept the fact that that could or could not happen. And then when I started doing that, over time, because I wasn't doing the compulsions as much, my habit was just to accept the thoughts. And when that happened and really stopped doing the compulsions, anxiety slowly decreased over time. And then I start to feel my true emotions in my relationship again. Right. And that was, it was a really, really profound moment. So hope that's somewhat helpful.
I think it's great too, Stephen, that you're open about your story to people, because I think it is an inspiration for people to see that someone with OCD can get help and can go on and have a great career and a great life. And that's just something that everyone needs to see, that there's people out there that have done it and that they can look up to. So,
oh, thanks, Patrick. Thanks, Patrick. Well, and it's amazing to see how you're just changing the game and innovating, right? Training hundreds of clinicians. You are so relatable, and you're doing all this advocacy work as well on Wednesday nights, Tuesday nights, just explaining what is OCD, how is it treated, in hopes that people can find your content and get better. So that's why also we're very appreciative of Made of Millions and the work that Aaron Harvey and his team are doing,
Absolutely.
because it's just there's a new way to educate, and it's online, right? People are Google searching out of fear much more than they're willing to talk to their primary care physician. And so what Made of Millions is doing is incredible. So thank you all very much today, and we're really excited for next week's series. All right, take care.